Let us paint a very clear picture of an ordinary season in a mature life. You are 74 years old. You feel completely wonderful. Your sleep cycle is beautifully deep, your daily energy is consistent, and you are actively spending your time doing the exact things you truly enjoy. You head in for a standard, routine physical checkup. Nothing special out of the ordinary. Your practitioner glances over your administrative chart, looks up, and says with a friendly smile, "You know what? Let us run a few extra tests today, just to be completely safe." 6 weeks later, you find yourself sitting inside a specialized surgeon's office. You are not there because you ever felt poorly or noticed a drop in your vitality. You are there because those just-to-be-safe screenings uncovered a microscopic abnormality. That single finding set off an unassisted chain of physical events that a mature system at 74 is simply not equipped to manage comfortably. Suddenly, the independent, peaceful lifestyle you were quietly enjoying looks completely different. This exact scenario plays out across the landscape of mature care far more frequently than the institutional network likes to acknowledge out loud. The actual data behind this pattern deserves a serious, unvarnished conversation. There is a critical reality that is rarely stated clearly during a brief 15-minute appointment. After crossing the milestone of age 70, some of the most common automated medical checkups can inadvertently cause significantly more harm than good. This does not happen because modern methods are broken. It happens because the fundamental risk-to-benefit mathematics of human biology shifts dramatically as the decades advance. Yet almost no one is sitting down in the room to perform that specific math alongside you. Today, we are looking closely at 5 specific routine screenings that are wise to thoroughly reconsider once you cross into your 70s. We are going to explore exactly why the biological math alters, analyze what occurs inside a mature system when routines run on autopilot, and outline a precise strategy that will completely transform the dynamic of your very next appointment. I urge you to stay with me through all 5 entries on our countdown, because item number 3 completely shatters traditional assumptions the moment you analyze its real-world tracking, and item number 5 is a quiet intervention that many individuals never even hear about until the structural consequences are already unfolding. But before we look at our framework, let us connect with our community. Please take a brief moment to drop a comment below letting me know your name and exactly where you are tuning in from today. I read through our community responses personally, and knowing who we are supporting helps us keep these deep dives tailored to your real-world needs. To understand why the parameters of care shift so radically in our later years, we must analyze our path through what I call the longevity lens. When a system is in its 40s or 50s, automated preventive screening functions with immense efficiency. You locate a potential vulnerability early, you address it aggressively, and you successfully purchase yourself 3 or 4 more decades of active, vibrant life. The long-term investment matches the biological output perfectly. The mathematics are clean, but the moment you cross 70, 3 distinct biological realities completely alter that equation. First, many minor structural abnormalities detected by automated tracking in mature adults will never actually cause you a single day of physical harm. They develop at an incredibly slow, near-dormant pace, produce 0 surface symptoms, and you will comfortably outlive them. However, the moment a microscopic marker appears on an official printout, the automated system rarely possesses a "leave it completely alone" button. It is designed to press the treatment button. Second, a mature body's natural tolerance for invasive stress naturally drops with age. A structural intervention that a 55-year-old bounces back from within 2 weeks can require months of exhausting recovery for a 78-year-old, frequently resulting in a loss of daily independence. Third, there is the powerful presence of the medical cascade effect. One automated test flags a tiny, harmless irregularity. That flag triggers an order for an advanced diagnostic scan. The scan notes a shadow and recommends a localized tissue biopsy. The biopsy leads directly to an invasive procedure, and the procedure introduces an unexpected complication. Suddenly, an individual who walked into a facility feeling perfectly healthy is forced to navigate a physical nightmare, all initiated by a routine checkup they never actually required. Keep this longevity lens firmly in mind as we count down our items. Let us look closely at our first specific checkup: routine colonoscopies after the milestone of age 75. Consider a graceful 77-year-old woman named Dorothy, a retired professional who had lived an exceptionally active life. Throughout her 50s and 60s, she had faithfully undergone her routine checks, and every single outcome returned completely clean. She possessed zero family vulnerabilities, had no digestive indicators, and felt completely wonderful. However, during a brief administrative review, her practitioner noted that, according to the automated schedule, she was officially due for another scope. Dorothy possessed minor personal hesitations, but because she did not want to appear uncooperative or difficult to her care team, she scheduled the appointment. The intense fluid preparation required the evening before the procedure, designed to completely clear the intestinal tract, hit her mature kidneys with immense, sudden physical stress. By the following morning, Dorothy woke up experiencing profound confusion, severe dizziness, and an absolute inability to stand flat on her feet. Instead of heading to her scheduled procedure, her family was forced to rush her directly to the emergency department. Dorothy was experiencing severe dehydration, and her essential electrolyte levels had dropped so dangerously low that her cardiac rhythm was facing immediate instability. She spent 4 consecutive days inside a hospital bed receiving emergency intravenous fluids. She never received the colonoscopy, and the absolute irony of the situation is that, according to the highest scientific standards, she never required it in the first place. The United States Preventive Services Task Force, the highly respected independent body that sets the gold standard for screening guidelines, officially recommends against routine colonoscopy tracking for average-risk adults over the age of 75. The clinical data is entirely clear. After this milestone, if an individual possesses no active indicators, no family vulnerabilities, and a history of clean previous checks, the physical risks of the intervention begin to heavily outweigh the structural rewards, and those risks are deeply real for a mature system. A literal tear or structural perforation of the delicate intestinal lining occurs in approximately 1 out of every 500 procedures. In a younger system, that represents a manageable, straightforward surgical correction. But in a system over 75, that exact same complication can result in emergency abdominal surgery, an ongoing collection bag, an extended hospital stay, and a prolonged recovery that fundamentally diminishes your long-term quality of life. Meanwhile, the minor, slow-moving anomalies most likely to be uncovered in an asymptomatic older adult develop at such a near-dormant pace that, in a vast majority of cases, they would never cause a single day of discomfort during the individual's remaining natural lifespan. What is wise to do instead? Speak openly with your team about non-invasive, stool-based evaluation alternatives that can be completed safely right inside your own home. These modern options can successfully flag genuine warning indicators without exposing your mature system to any procedural stress. Of course, if you are experiencing active indicators, such as unexpected changes in your standard digestive habits, that completely changes the biological equation, and you must seek direct guidance immediately. Let us advance to number 2 on our countdown. Aggressive, automated screening for low-risk individuals. We must be highly precise here, because this topic requires deep nuance. This is absolutely not a suggestion to ignore your health or neglect your body's signals. Targeted screening has preserved millions of lives over the decades, and it can absolutely protect yours. What the clinical data reveals, however, is that after age 75, aggressive, automated screening in average-risk, completely asymptomatic individuals carries a substantial overdiagnosis problem, and overdiagnosis leads directly to unnecessary, aggressive overtreatment. Overdiagnosis means that modern imaging technology has become so exceptionally sensitive that it can easily detect microscopic anomalies that are, biologically speaking, barely awake. These are tiny, slow-moving cellular clusters that, if left completely unbothered, would never spread, never produce a single surface symptom, and never shorten your life by a single hour. You would comfortably live alongside them for the rest of your days without ever knowing they were there. But the very moment a report records an official label of abnormality, the automated clinical machinery turns on. Local tissue biopsies, urgent specialist referrals, and intense treatment discussions move forward with immense momentum, completely ignoring whether that minor anomaly ever posed a genuine threat to your daily vitality. Consider the real-world case of Richard, a 79-year-old retired technician. He was incredibly sharp, completely independent, and spent his weekends out on the water. During an automated checkup, a routine marker returned slightly elevated. A subsequent tissue biopsy confirmed a low-grade, slow-moving cellular irregularity. His specialist immediately recommended undergoing an intense course of localized radiation tracking. Richard trusted the automated machine and moved forward with the recommendation. Within less than a year, the aggressive intervention left him managing constant systemic fatigue, ongoing pelvic discomfort, and a quality of life that dropped dramatically. Stories like Richard's are heavily documented throughout peer-reviewed literature. Mature individuals who, looking back, wish they had understood that the minor irregularity was something they could have easily lived alongside, rather than something they needed to fight at the expense of their daily strength. Data published in the New England Journal of Medicine confirmed that a substantial portion of automated screenings in individuals over 70 uncovered clinically insignificant findings, meaning the subsequent treatments offered zero survival benefits while introducing heavy, long-term physical side effects. What is wise to do instead? Have an entirely honest conversation with your care team about your specific, personal risk profile. If you possess an active family history, known markers, or physical indicators, proceed with targeted tracking. But if you are at average risk and feel completely wonderful, ask your team directly. If we run this test and find a minor, slow-moving anomaly, what are the realistic treatment options for someone of my specific age, and would we actually need to touch it? That single question completely changes the dynamic in the room. Let us advance to number 3 on our list, and this is an entry that catches many mature adults completely off guard because on the surface it sounds incredibly responsible. We are looking closely at routine cardiac stress testing conducted in individuals who possess absolutely no chest pain, zero tracking issues, and no shortness of breath. The scenario typically unfolds during a standard checkup. Your care team looks over your file and says, "You are 72 years old now. Let us just run a routine stress test on a treadmill to make sure your heart is doing completely okay." It sounds completely benign. It sounds like thorough, preventive care. But here is the immense biological challenge that remains unspoken. Cardiac stress tests conducted in mature individuals who show no symptoms carry a false positive rate that can reach 40% or higher. That means nearly half the time, the machine flags a scary-looking abnormality on the printout when your heart muscle is actually functioning completely fine for your age. The automated clinical machine cannot simply look at an abnormal finding and shrug it off. Once that false alarm is officially registered in your files, you are instantly launched into the very next phase of automated tracking, a cardiac catheterization. Catheterization is a serious invasive procedure that requires threading a long, thin tube directly through your delicate blood vessels, typically entering through your wrist or your groin, and pushing it all the way into the interior chambers of your heart. This is a high-level intervention. The procedural risks are deeply real for a mature system and include localized bleeding, blood vessel damage, sudden tracking irregularities, and in rare instances, it can trigger the exact physical distress event you were trying to prevent in the first place. And here is where the math becomes even more counterintuitive. If the invasive catheterization uncovers a partial minor narrowing in an artery, which is an incredibly common natural structural finding in adults over 70 who are walking around with zero daily issues, you are highly likely to receive an automated recommendation for a cardiac stent. However, multiple landmark clinical trials, including the widely cited ischemia trial, closely analyzed these exact scenarios. The data revealed that placing a stent in individuals with stable, silent vascular narrowing offered absolutely zero reduction in long-term events, and it did not extend their life by a single day compared to simply utilizing conservative lifestyle adjustments and standard supportive habits. Let us look at that reality again. The invasive stent provided no statistical advantage over gentle management, yet it exposed the individual to all the immediate risks of surgery. Furthermore, receiving a stent instantly places you on a permanent, lifetime routine of intense blood-thinning compounds, which carry their own heavy, long-term risks of internal tissue strain and easy bruising. Suddenly, an individual who walked into a clinic feeling completely vibrant and well is redirected down a path of false alarms, invasive tubes, permanent foreign structures in their vessels, and a lifetime of intense daily pills. Yet, statistically, their heart is no better protected than if they had simply focused on a consistent 30-minute daily walk in the fresh air. What is wise to do instead? If you currently experience no chest pressure, no unexplained breathing difficulties, and zero sudden dizziness during your daily activities. Routine stress testing is looking for structural anomalies in a demographic where minor narrowing is completely normal, and where invasive corrections do not automatically equal a longer life. Speak with your team about optimizing your real, foundational lifestyle factors instead: your daily activity levels, your quality of sleep, your blood sugar balance, and your emotional stress. That is exactly where the genuine health gains are secured. Moving to number 4 on our countdown: routine bone density DEXA screening, followed by an automatic pipeline of immediate medication. I want to look at this topic with immense care and precision, because structural bone thinning is a very real challenge, and unexpected balance failures can be devastating for a mature framework. I am absolutely not questioning the reality of natural bone density changes over time. What we are thoroughly evaluating is the automated pipeline that frequently unfolds the moment a mature individual over 75 receives their official T-score printout. The standard bone scan detects a lower density, a finding that is completely typical for a mature framework. Instantly, the automated system generates a prescription for a class of bone medications known as bisphosphonates. You begin swallowing these tablets week after week, assuming your skeletal structure is now perfectly shielded from future fractures. But here is a serious, long-term structural reality that is rarely mentioned clearly. Prolonged, unassisted use of these specific bone compounds over many years has been clinically associated with a rare but severe condition known as atypical fractures of the thigh bone. These are spontaneous stress fractures that can develop right inside the densest bone in your lower body, the exact structural pillar you were actively trying to protect in the first place. These fractures can occur without a sudden fall and frequently require complex surgical hardware to correct. Additionally, these long-term compounds are linked to deep, localized circulation disruptions inside the jawbone, resulting in tissue irritation that is exceptionally difficult to treat. Meanwhile, the single most effective intervention for preventing a skeletal fracture in a mature adult, outperforming any chemical tablet on Earth, is comprehensive fall prevention. I am talking about targeted balance training. Long-term studies demonstrate that including a dedicated, gentle movement practice like Tai Chi can reduce your real-world risk of an unexpected balance failure by nearly 50%. Focusing your daily energy on removing hidden tripping hazards from your living space, installing solid supportive bars in slick areas, evaluating your routine for side effects that cause brief dizziness, checking your vision regularly, and ensuring your daily meals contain a beautiful abundance of clean protein and vital cofactors, these physical interventions reduce your fracture risk far more meaningfully than an automated pill, and they carry absolute zero side effects. This does not mean you should never utilize supportive bone care. There are absolutely specific situations where targeted stabilization is necessary, such as individuals who have already managed a fracture or who possess highly unique structural risks. But allowing a routine automated scan to lead directly to automatic, long-term medication for an active, healthy individual who has never once broken a bone is a major conversation worth pausing for, not a foregone conclusion. Before you accept a lifetime pipeline of tablets, ask your care team, can we thoroughly analyze my real-world balance factors first? And what is the actual mathematical reduction in fracture risk from this pill compared to me joining a structured balance and strength routine? Now, this brings us to number 5 on our list, and it is perhaps the most quietly consequential intervention on our entire countdown. We are looking at automated ultrasound screening of the carotid arteries in individuals who show absolutely zero neurological indicators. The carotid arteries are the large, primary pathways running through both sides of your neck, responsible for delivering fresh, oxygen-rich blood straight to your brain. The automated concept sounds incredibly logical. If we run a quick sound wave scan over your neck and find a minor narrowing or plaque accumulation, a specialist can surgically clean out the vessel and lower your long-term risk of a vascular event. It makes perfect sense to the analytical mind. But the real-world operational data is far more complex, and for an individual with zero active indicators, it can be far more hazardous than it appears on the surface. Here is the critical, underlying fact. The surgical intervention used to mechanically clear a neck blockage, known as a carotid endarterectomy, carries an immediate 2% to 3% risk of inadvertently causing a sudden neurological event during or immediately following the procedure. In a mature individual over 70, especially one balancing other minor health factors, that immediate risk can be substantially higher. Because of this specific friction, the United States Preventive Services Task Force explicitly recommends against routine, automated carotid artery screening for adults who show zero symptoms, meaning individuals who have never experienced a mini-stroke, temporary changes in their visual field, or sudden neurological weakness. Their extensive data analysis confirmed that in an asymptomatic person, the immediate danger of surgical harm heavily outweighs the long-term benefit of finding a silent narrowing. Here is why that happens. A vast majority of adults over 70 possess some degree of natural narrowing or stable plaque inside their neck pathways. That narrowing has often developed gradually over 20 or 30 years. It is completely stable, silent, and is causing your brain absolutely zero daily harm. It is simply a natural part of your personal architecture. But when you screen for it routinely on an automated schedule, you find it, and a well-meaning surgical team will naturally recommend fixing it. The immense tragedy is that the physical act of entering a stable, silent vessel to scrape away a narrowing can dislodge a microscopic piece of that quiet plaque, allowing it to travel directly up into the brain. The peer-reviewed medical literature contains thousands of instances where individuals walked into a routine, automated checkup feeling completely wonderful and left on an entirely different physical trajectory than they ever imagined, not because of the hidden narrowing that was uncovered, but because of the aggressive intervention that followed. What is wise to do instead? If you show no active indicators of a neurological shift, meaning zero sudden changes in your facial symmetry, no temporary weakness in your arms, no sudden visual disruptions, and no unexplained severe headaches, then an automated neck scan is generally not recommended. Your single best investment is to focus your valuable energy on managing the real, modifiable drivers of vascular health, supporting smooth blood pressure tracking, maintaining active daily movement, and supporting healthy circulation. If you ever do experience a brief neurological indicator, even one that resolves completely within a few minutes, that changes the entire situation instantly, and you must seek professional evaluation immediately. To ensure you can step into your next appointment with absolute clarity and control, I want to offer you a highly practical framework. I call it the 5-question protocol. Write these questions down on a clean card, save them inside your phone, and bring them with you to every single routine physical review. The moment a screening is recommended, just to be safe, politely pause and ask your care team these 5 questions. Question 1. What is the false positive rate of this test for someone of my exact age? This instantly reveals how likely the test is to register a false alarm, saving you from being launched into unnecessary, stressful follow-up procedures when your body is actually functioning fine. Question 2. If this test uncovers a minor abnormality, what are the realistic treatment options for someone of my current age and health status? This forces the discussion away from mere printout findings and drives the conversation toward real-world outcomes. If the realistic recommendation for a slow-moving finding is simply to watch it, you may choose to avoid the stress of the test entirely. Question 3. What is the exact procedural risk of the treatment we would likely pursue? This is the single question most adults never think to ask. Every intervention carries an immediate physical price. You deserve to know that risk up front so you can balance it against the long-term reward. Question 4. What occurs inside my system if we choose watchful waiting and regular monitoring instead of immediate treatment? For a vast majority of minor structural changes found after 70, slow, careful monitoring is a completely legitimate and often superior option that preserves your daily vitality. Question 5. What is the most effective, non-invasive lifestyle intervention for this specific concern? Because very often, as we have seen with bone density, heart health, and vascular care, targeted balance routines, gentle nutrition adjustments, and simple daily walks can completely outperform an invasive procedure, carrying a fraction of the risk. Any wise, compassionate practitioner will completely welcome these questions. They will respect your intelligence and your dedication for asking them. And if a source ever dismisses these inquiries or makes you feel difficult for wanting to understand your own biology, that provides you with very important data regarding whether that specific individual is the right fit for your long-term wellness journey. There is a profound difference between a medicine that simply generates a list of findings and a medicine that actively helps you live your life well. After crossing 70, the core goal of your personal care should never be to collect an administrative checklist of technical abnormalities. The goal should be to fiercely protect and extend your actual quality of life, your physical independence, your daily energy, and your capacity to do what matters most to you. The wisest mentors I have ever known fully understand that doing less sometimes requires far more deep wisdom than doing more. Recommending a path of careful, watchful waiting requires significantly more courage than ordering another automated scan. You possess the absolute right to know what a test is searching for, what occurs if an anomaly is found, and whether the subsequent treatment will genuinely upgrade your daily peace. Modern methods have provided us with incredible tools, but a tool is only helpful when it is utilized in the right context, at the right time, for the right individual. You are that individual, and you deserve a wellness experience that is built around your values, your comfort, and your physical freedom. Thank you so much for exploring these insights with me today. Take outstanding care of your health, look after one another, and I look forward to sharing more research-backed data with you right here in our next episode.